Welcome to Future Talk. On today's program, we're going to talk about new wellness tools. By new wellness tools, I mean new means of organizing health information and providing better access to it for doctors and patients alike, so they can make better informed decisions about medical diagnosis and treatment, as well as disease prevention. A bit later in the show, we'll have an on-location interview with Michael Deneen, who's the Director of Strategy Management for the U.S. Military Health System, but who will talk about a new type of organization in the civilian health sector called an Accountable Care Organization, which aims to provide a continuum of care even as the patient goes from one medical facility to another. But first, I'll be talking with Martin Entwistle, founder and CEO of a company called Enigma, which developed a technology to provide better information sharing between doctors and patients in order to aid in clinical decision-making. Enigma's technology was acquired by the Palo Alto Medical Foundation in 2008, and Martin now serves at the Palo Alto Medical Foundation as co-executive director of the David Drucker Center for Health Systems Innovation. He was also trained as a physician and orthopedic surgeon in the United Kingdom. Martin, what is your technology all about? How does it help the patients?
Essentially, the technology is about personalization. It's about taking all that myriad of information we now gather about patients through electronic health records, etc., and turning that into a program of care specifically tailored to their needs, taking into account their particular situation, the medications they may be on, etc. So it's about personalization being important for people to engage in their personal plan of care.
So this gives doctors a better view of the patient's medical condition so they can make better decisions?
Both the patient and the doctor and other people increasingly important in their ongoing management, nurses, case managers, etc.
Now let's say I were a patient at the Palo Alto Medical Foundation. Would I use the system myself?
Yes, indeed. The system is set up so that the doctors and nurses have one view and the patient has another, but it's a view of the same picture, if you will. So as a patient in the Palo Alto Medical Foundation, we provide an online personal health record, one of the first places in the country to do that, now increasingly adopted elsewhere. And when you go into your personal health record online, you can see your plan of care around a particular disease or disease process, providing you this personal view of where you're at, the goals that you're targeting, your current situation, and advice around how you could improve your situation.
Does this give me better access to the doctors? Usually, if you have a question you want to ask a doctor, you might have to make an appointment and see him in person. Does this eliminate the need for that? Like you can access the doctor pretty much any time?
Well, that is part of it, although one of the objectives is to better share the care of an individual across a team. So you might actually see your doctor less. Now, that might sound a little bit negative, but the aim is that there are other people that can be part of your team and ongoing plan of care that are equally important. So you see the doctor when you need to see the doctor, particularly for the formulation of your management, changing your medications, etc. But when someone else is appropriate to help you keep with your program and keep with your goals, such as a nurse, that person would be in the picture. So it's about sharing and coordinating the care across that team.
So if I have a question, I would post the question through my computer, and then somebody would decide who to assign that question to?
Well, you're very much actively involved with the members of your team. You know who they are, and they've got ongoing contact and dialogue with you. But at one end of the spectrum, you have the system providing you advice on an ongoing basis, tracking how you're doing. Let's take an example. If you're a diabetic in the program, then we'd be collecting information about how you're doing with managing your blood sugar by collecting data from your home monitoring device, sending it up maybe through a wireless device so it becomes part of this picture. And then everyone can share and see how you're doing, including yourself. Knowing that you're on track or off track will then affect how people intervene with you. But the aim is to provide you information to help you engage and take responsibility for your care with people supporting you to do that.
Now, a lot of people seem to be getting into this business of medical information providing. In fact, We have a short video clip about Google Health, which is Google's offering in this market, a way of monitoring your own medical conditions. We're going to air that video, and then I'd like to ask you what you think of their approach. So let's go ahead and roll that tape.
Justine is 38 years old and works for a local nonprofit outside of San Francisco, where she lives with her 7-year-old son. Justine wants to stay healthy, but with so many responsibilities, she has a hard time setting up and maintaining her fitness goals. A friend at the office told her about Google Health. Google Health offers personalized fitness and health trackers and a host of integrated applications and devices that can help you better manage your health, from your diet to tracking your medications. You can even get customized articles and information based on your personal health summary. To try it out, Justine set a goal of running 5 miles every 2 days. She tracked her progress toward this goal in Google Health and used the personalized notes feature to jot down how she felt on each run. Seeing her improvement over time encouraged Justine to keep going and to set her goals higher as she realized she could meet them. She even signed up for a half marathon in her neighborhood. At the request of her doctor, Justine also started tracking her caffeine intake as well as her sleep patterns. Luckily, Google Health allows her to create trackers for anything she likes. Over time, the data in Justine's Google Health profile started telling a story. It looks like Justine doesn't sleep as well when she drinks more than 2 cups of coffee a day. For Justine, the information in her Google Health profile empowered her to keep running and make changes that helped her sleep and feel better. Health and wellness goals are easier to meet with accurate information at your fingertips.
So that was a video clip about Google Health. Now, what do you think of that approach? Would that be compatible with the approach offered by the Palo Alto Medical Foundation? Would this supplement it, or would you not need that if you were on the program at PAMF?
Well, in our own organization, we do pretty much all of that as part of what we do, providing the systems that we were talking about a few minutes ago. We saw some very important features there that I like a lot. You're seeing tools to help the individual engage in their plan of care. They can select the things that are meaningful to them, which are more motivational than just telling people to do things. We saw tracking of information so you can see your performance. All those are good and exciting things, but it's a system that sits apart from our doctors and our nurses. Google Health do provide interfaces to link it back to the medical record, but we've taken the track of building that functionality into what we do with our system. So the information of the type you saw there, the goals, the tracking, is there at our fingertips to help us day in, day out support that individual, the patient, as well as provide information to the doctors and nurses. Everyone's on the same page doing the same thing.
Well, one thing I liked about your system is that it sounds like, for the diabetics, the information is recorded electronically. It's automatic. The patient doesn't have to do anything. I'm wondering how many people would have the discipline to write down or to enter in their computer all this information every day, especially when they're feeling well. So it seems to me that the less you ask the patient to do, the more likely they are to do it.
Agree with that, yes. Our experience shows that making it simple to get the data in is going to make a big difference, because what people really want is the benefit of the data, the ability to see how well they're doing against their goals, not the labor of putting it in. But I think it's also important to recognize that these kind of tools don't suit everybody. What we're learning is that there are certain people of certain types that will engage with this sort of thing, but not everyone. So we have to have a flexible approach that suits different styles, different learnings, different approaches to how I see myself and my condition and my diseases, and how I want to manage them.
Now, the capabilities that you've described so far at the Palo Alto Medical Foundation, are these all things that are operational right now?
Yes, we have these operational. We've been building this kind of capability to go from the identification of risks, people who may be at future risk of heart disease, by way of example, to people who've actually got the problem, people who have got hypertension or diabetes. Because we're trying increasingly in this world to intervene early, prevent the problems before they become problematic. Those lead to admissions, obviously the downside to your own health of having that kind of problem, And if we can prevent it, so much the better. Of course, we can't prevent the problems for everybody. So when you start getting the problem, we need to be able to intervene and help and support and manage those conditions. We think of it as a spectrum. Individuals move over time up and down and around this space from needing prevention to needing management.
You're thinking of adding additional capabilities in the future. I'm assuming the system is not complete yet.
It's always being developed. I mean, this is a very large area that we're trying to work in. And yes, we are. Recently, we added in taking this approach for teenagers, for example, trying to help identify issues that they may face. Some of them are the classic things about their behaviors, risky behaviors, etc. Of course, we're trying to encourage good eating habits and good exercise habits. And at the other end of the spectrum, we're very, very interested in seniors and how we can better manage seniors living in their own home. And so we're working hard now on improving our tools to tackle that end of the population.
Okay. We're going to move on to the next segment of our program. I recently spoke with Michael Dineen, MD, PhD, and Director of the Office of Strategy Management for the U.S. Military Health System, although we spoke about a new type of civilian health system called an Accountable Care Organization, or ACO. Dr. Dineen previously served as Director of Medical Services at the National Naval Medical Center in Bethesda, Maryland. A psychiatrist by training, he also served as a special psychiatric consultant to the Secret Service and the State Department, and he also has special expertise in military psychiatry acquired during the Desert Shield and Desert Storm campaigns. We've broken the interview into two parts. This will be part one of my interview with Michael Dineen. Let's roll that tape. What exactly is an accountable care organization? What's the purpose of that type of organization?
Well, the purpose of the organization is to be accountable for something. And in the military health system, we've said that we want to be accountable simultaneously to have people ready to face the challenges they may face in health, whether they be infections or accidents or those kinds of things. We want to be able to say that we're accountable for improving the health of a population that we serve. That's number two.
When you say accountable, accountable to whom?
It's a great question. In the military health system, we're accountable first to the Secretary of Defense, but really we're accountable to the American people. They're the ones that pay the bills. But more importantly, we're accountable to each and every patient to be sure that they feel like when they come for care that they'll get something that's of very high quality and that won't harm them. And that's the third component beyond readiness and population health. It's an experience of care. We're accountable to the patient to provide an experience of care that's safe and effective and efficient and that makes them feel like someone actually puts them at the center. And then finally, as Secretary Gates says, the cost of healthcare in this country is unsustainable. So we have to be accountable for being good stewards of the government's money, or of the taxpayers' money.
Well, is there a problem with the way health care is delivered now? Usually an organization is designed to solve a problem. So what's wrong with the system now that it needs a new organization?
Well, there are basically two problems from our perspective. One problem is that we pay for the wrong things. Right now, in this country, we pay for volume. So we have a fee-for-service model. So the more that is done for a person, the more the providers or the doctors and the hospitals get paid. So that essentially provides a tremendous incentive to provide lots and lots of services, and that's one of the things and especially use lots and lots of technology, and that tends to drive costs up. The lower cost interventions like coordinating care, doing education, helping with nutrition, those aren't actually even paid for in the current system. So one of the problems that needs to be fixed is the lack of incentives for health. We now have incentives for sickness, and so that's one thing that has to be fixed.
So what would this type of organization look like? Who would its members be? Would it be a hierarchical organization where somebody in the organization decides what treatment you're allowed to get or what tests you're allowed to get?
Well, actually what it would be best based on is the best evidence that's out there, and this is where we really want to leverage technology so that doctors at the time that they're seeing a patient will actually have access to decision support so that they can say for a diabetic, gee, you haven't had your blood pressure in control, or you need to have better control of your cholesterol, or we need to be taking care of your kidney. And that would be supplied by a very powerful electronic health record. The other thing that technology would help us with is connecting the dots between what just happened at a hospital and then what's happening back when the person comes back to their primary care doctor. And that's not happening frequently now.
So you're talking like something like a national healthcare database where your entire medical records are all stored in cyberspace and any doctor who treats you has instant access?
That would be the long-term vision, that's done and in a very safe way, so it doesn't lead to problems with privacy, invasions of privacy and such. Probably the best example of electronic health records that are working now are in our system, in the military health system, the Department of Veterans Affairs, and Kaiser Permanente. But Kaiser Permanente has done particularly well in that what they have is a single electronic health record where not only do the doctors have access to all the information, but the patients themselves do. And the patients now are able to see what's gone on every time they've touched the Kaiser system, so that they can take personal charge of their own health. And I think that's where the real advantage is a truly accountable care organization will be accountable in real time to the patient, so that they get their lab results right back. They know how well their system is doing in treating the illness that they have.
So that was part one of my interview with Michael Deneen. Now he's talking about following a patient as he goes from one place to another. Now is that compatible with what you're doing at PAMF? You might have a patient who is treated at PMF some of the time, but sometimes they have to go to Stanford Hospital, sometimes they go to UCSF. Once a person is outside of PAMF, can you still track them, or do you plan to do so in the future?
Yes, we do. Today, that's somewhat problematic. It's not as good as we'd like it to be. To get information when our patients go to Stanford requires some effort to get the information back. It shouldn't be like that. It should be seamless to be able to know what's happening with the patients in the hospital admission and on their discharge. And likewise, when individuals go in for an admission, the doctors in the hospital should be able to get access to the information from the primary care environment, because the benefits of that are huge, avoiding duplicating tests that have recently been done and just keeping the care coordinated. So that is a direction we're moving in very fast. He's talking about accredited care organizations that are a driver for this. It's a very positive move. Right now, this model is being experimented with. It's being tested. If it works, it could be a direction of travel for a large part of the sector, the health sector, the way we move and the way we deliver care. The jury's out at the moment, frankly. It's somewhat of an experimentation. Although I have to say, people believe that this is a direction we're all going to move in. It makes a lot of sense that we coordinate what we're doing with our patients and provide a better experience.
Well, is this related to social networking? You have things like Facebook where information can be posted and anybody can see it. Is it basically resting on something similar to social networking technology?
Not really. Social networking, I think, is an increasing important part of what is provided for patients. If we think of social networking, it's the interaction with other people who may share similar experiences or conditions. That's an important way of learning and improving what you're doing. But as I think we all know, those social networks tend to be open. Information tends to be shared without too much regard for privacy. And we've got a big responsibility with information that's provided in the context of delivery of care that requires protection. So the two are similar, if you will, but they're not the same thing, and we shouldn't confuse one with the other.
We're going to go on to the next segment, which is part two of my interview with Michael Deneen, and then we'll come back and speak for a few more minutes with Martin Entwistle. So let's go ahead and roll part two of that interview. So does that mean that there would be, say, one person who is ultimately responsible for coordinating your health care, no matter how many different doctors you went to see?
That is the goal. That is what's missing in healthcare in the United States right now. There is no one who is responsible for all the aspects of an episode of care, from the time someone says there's something wrong to the time that you're all better and back to your fully functional state. And if we could, if that could be where the country goes, that says there's like, one person calls it an offensive coordinator, so that all the players on the team that takes care of you, somebody's making sure they're all doing their part and they're all working together to work like accomplishing a play in football.
Now, how would this work from the standpoint of the patient? Would this person who is ultimately responsible for you have a personal relationship with you or know you, or?
Right. In some cases, we think that the centerpiece of the accountable care organization is something called the patient-centered medical home. And there you would have a personal physician who would be the architect of all of your care. But for people with more complex illness like cancer or multiple chronic diseases, you might need what's called a case manager or care manager that would have that relationship to you and could in a more intensive way reach out to all the people that are involved in your care.
Now, the fact that you create an organization and you give somebody this title of being in charge of your health care, does that in itself make it happen? Because to manage a large caseload, for example, it's hard to see how you could spend a lot of time on any one individual.
Right. One of the things that we're that is a learning in trying to go this way is that we've been underspending in this country in primary care. And so we've forced primary care doctors to have very large panels of patients and insufficient time to really do what's necessary to help them chart their course for health. And so some places, there's a group in Atlantic City right now that have actually doubled the amount that they're spending on primary care. And by doing that, what they've managed to do is reduce the amount of inpatient admissions. So the total cost of care for the patients has been reduced, while the amount that's been spent on primary care has actually been doubled. Because what we think now is that if we got much better primary care, we'd essentially be emptying out hospitals in this country, because a lot of the hospital admissions are due to lack of coordination and lack of good management of outpatient illness.
What do you think is the most wasteful part of the healthcare system? There are often proposed cuts here and there on little things, but what kind of area do you think would be best to cut where we could achieve the most savings without compromising care for individuals?
That's really risky. So most people that have studied healthcare costs in this country would say that approximately 1/3 or more of all healthcare delivered in this country is waste. The problem is identifying which that 1/3 is, because the other 2/3 are very valuable things that we're doing to help people get better once they've gotten sick. And I think that many of the efforts to cut out waste have been like taking a sledgehammer to something where we really need a scalpel. And what we're hoping to do is to attack this in a very thoughtful way. So the president this year, President Obama, has actually just yesterday announced a new program where the effort is going to be primarily on eliminating unnecessary readmissions to the hospital. So about 25% of people in the Medicare age, if they've been admitted for congestive heart failure, they'll be readmitted within 30 days. We know that's unnecessary in many cases. So we're going to focus in on those people where there's both suffering and costs that can be avoided. Because almost everybody would agree, if we can do better outpatient care after people leave the hospital and avoid a readmission, that's both improved quality and reduced cost.
So is the ACO largely an administrative type of organization, or is it involved in actually providing the care itself?
Some of us who just were on a panel talking about accountable care organization wonder if that term really ought to be used. Maybe we should just say accountable care. That really it's about moving from where no one's really accountable for the care of a person over time to identifying that person who feels accountable and then collaborating with others to get the best outcomes at the lowest cost.
Okay, that was part 2 of my interview with Michael Deneen. Now, he said something about having one person in charge of your medical care. Does that relate to what you're doing at PAMF? You might have a lot of different doctors looking at a patient's medical records, but is there one person who is responsible for making the ultimate recommendations?
Yes, that's a model that we are following and trying to move much more towards. The question is, who should that one person be? In many cases, the obvious person is the primary care physician. But in other situations, it may be another member of the team. You heard him talk about a care coordinator or a care manager. So I think what we're thinking about is a flexible team in which the patient has got an input as to who is on their team, where they identify the people that are important to them. The person that's the leader has got to have the responsibility for ensuring the outcomes for that individual, positive outcomes, positive experience. And the obvious person is the doctor, but not always will that be the case.
Now, sometimes doctors might have different opinions. That's why they always tell you to get a second opinion. what would happen in a case like that? Would someone say, well, I'm the leader, so will only present my opinion?
Well, that's what the leader of the team has got to be able to broker, if you will, to help the individual make choices between the options that are available to them. So we need to bring in the idea of advocacy for the patient, to help the patient make decisions that they buy into and they feel are best and appropriate for them.
Do you see anything in the future like video conferencing, for example, where you can talk to your doctor or maybe several doctors at once without actually having to show up at the office?
Definitely. I think there are quite a lot of new technologies such as that have got a strong role to play. Again, we've got to be flexible. They're not always appropriate for all patients. We've got to learn when to bring them in and when they have a positive role to play and when they may get in the way of the care process.
Do these tools also help the doctors perfect their own craft just by giving them more exposure to another and knowing what other doctors are thinking, so they might be less isolated, they might sort of have a synergistic relationship with each other?
Exactly. I mean, when we're very busy people, it's hard to get together, it's hard to share experiences, which in past days used to be easier to have rounds and meet and learn. So that's an important dimension, absolutely.
Have you already gotten much feedback from patients as to how well they like the system and how much they use it?
Yes, we've got some very good feedback from quite a number of patients, and we've learned that in other situations, as I mentioned earlier, it isn't perhaps the most appropriate approach for them. And we have to take a different tack with them and work out how we take a more supportive process without necessarily using all the tools. We shouldn't just impose them on people because we think they're the best way to go.
We're almost out of time, so this will have to be the last question. Some people think that the patient should be the empowered one, the one who is ultimately responsible for his care. Is this model neutral in that regard, or?
We actually call our program Empower. It is about trying to empower the individual to make decisions, have the information, and take responsibility for their health and outcomes.
Okay, great. We have to wrap on that note because we are out of time. Thank you very much for being here. I'd like to thank my two guests tonight, Martin Entwistle and Michael Deneen, who I interviewed remotely. Thank you for watching. Visit our website, www.futuretalk.net. I'm Marty Wasserman. See you next time.